is here to talk about Parkinson's disease. Dr. Kosa received his medical degree from the University of Kansas School of Medicine and completed his residency at the Mayo Clinic. North Kansas City Hospital also offers 2 programs that improve quality of life for patients battling Parkinson's. The programs are called Rock Steady Boxing and Big and Loud. I've heard of those. They're helping many people in our community, sounds like some maybe are here, improve balance, strength, agility, and daily functions. We are the only hospital in the Kansas City area that offers Rock Steady Boxing program. Following Dr. Kosa's presentation, our certified Rock Steady coaches from the Community Health and Wellness Department, Jill Sartain and Shanna Watt, will provide an overview of the program, and Brent Fowler, one of our occupational therapists, and Sarah Kennedy, our speech language pathologist, will talk about Big and Loud. At this point, please join me to welcome Dr. Kosa.
All right, thank you, Randy. Can everyone hear me okay? Wow, quite a turnout. I see a lot of familiar faces, so thanks everyone for coming. So we'll get to the exciting stuff in a bit with Rocksteady and what these practical things we can do. But I thought I would go over where are we with Parkinson's today, just kind of a general overview, and then we'll have time toward the end for questions that you might have. So, this is a little hard to see, so I'm going to see if I can get a little closer. So this is from the Michael J. Fox Foundation. It's a bunch of facts and figures. But 1 in 100 people over the age of 60 have Parkinson's, 60,000 new diagnoses a year. There's a lot of symptoms, and we'll get to these that are not the typical symptoms of Parkinson's, so we'll talk about that. There's no specific tests that we have. We don't have a blood test that says, hey, it's Parkinson's. This little part here is the first drug that came out, which is dopamine, is what we need, is, in my opinion, and many others, still the best drug, even though there's been multiple medications that have come out. So there's 1 million people in the U.S., and it says 5 million. I've seen anywhere from 5 up to 10 million worldwide with Parkinson's. So it is a chronic, progressive, degenerative brain disorder. It affects movement, but other things are affected as well, which we'll get to. So we have the symptoms of bradykinesia. So what does that mean? So that's just slower movement all around. Postural instability, so that's unsteady on your feet, might fall, might be prone to passing out, that sort of thing. Rigidity, so that's stiffness, that's kind of not this normal smooth range of motion. It's kind of they call it cogwheel rigidity, where it's a kind of a ratcheting tightness. And then of course a tremor that you're probably all familiar with, usually it's a resting type tremor, which a resting tremor is you're not using it. You're just say you're sitting watching television and the tremor would be going. A lot of times it comes out during gait as well. So it's a deficiency of the neurotransmitter dopamine, okay? So this is this area right here in the brainstem is called the substantia nigra. That's where a lot of these dopamine cells are. And those, we begin to lose those. We don't know what's the exact cause of this. Like what I do, a lot of the diseases I deal with, we don't know the root cause of them. Alzheimer's, MS, Parkinson's, ALS. If we could get to the bottom of that, I think we'd have a lot better treatments. So there's a complex network here that interfaces with the cortex of the brain to initiate movement, maintain movement, smooth movement, gait. So it's very complex circuitry. And this is this is a normal situation. So we have a neuron with dopamine that's releasing into the synapse, and that's going to bind to receptors here. The receiving neuron is going to lead to an effect. And what's happening here is we're just losing the ability to make and transmit the dopamine. So it's a chemical messenger that's used. So we have in the brain communication, we have chemical that then lead to an electrical impulse, and those are kind of an alternating network of the chemical, electrical signaling. So it allows for coordination of movement. So patients that lose this ability have less ability to control their movements. And we'll get to, so I get this question a lot, is my Parkinson's, is it fatal? Typically not. It's a more of a chronic process that happens that really affects quality of life. Falls can be fatal, those sorts of things. Getting pneumonia, that sort of thing can be fatal, and that can happen later in the disease process, and that's where really helping to maintain the balance as strongly and as much as we can is very important, and that's where our PT and Rocksteady come in. Unfortunately, it's incurable. I don't have a magic pill or procedure that's going to reverse Parkinson's or stop it. Most of the time, the diagnosis is pretty straightforward. Can almost make it within 5 minutes of walking in the room and just interacting with the patient. You can see that it looks like Parkinson's. But there are times when it gets complicated and, well, I don't know, maybe it's Parkinson's, maybe it's this other kind of tremor. So that's what we'll do, this thing called a DAT scan, which is, we're working on getting this one out in North Kansas City. We've been sending these out to KU. But it's maybe 5% or less of cases might need a DAT scan. But it's looking at the signaling of dopamine with a research study in the brain. It doesn't say you have the typical idiopathic Parkinson's, or that's the one that we're thinking of, we're speaking of today, but it will just say there is Parkinsonism, and there's other rarer things that it could be. So, a lot of these diseases, when we don't know the specific cause, that means, basically that means it's very complicated. So we've got probably some environmental factors, definitely have genetic factors involved. And that's what makes it challenging for us to find what is the root cause of why people are getting these diseases. So they vary in degrees of onset. So Michael J. Fox, of course, got it very early. But typically it's a diagnosis that comes on after the age of 60. But everybody's different. The way they progress, some of the manifestations they may have. So who's at risk for getting Parkinson's? So if you're older, over the age of 60, there's a risk of Parkinson's. Rare to be diagnosed in the 40s. I think I saw one of the youngest diagnosed cases was in 18, I think. So yeah, that's really an exception. Males are a little bit more likely to get Parkinson's than females. If there is a family history of Parkinson's, that does confer some risk to the children, although it does not mean that if a parent has Parkinson's, that the children are definitely going to get it. They're looking at all sorts of genes, and it's very complicated, the genetic aspects of this. Repeated head trauma, so Muhammad Ali is an example of a boxer who dealt a lot more blows than he took, certainly, with his success, but unfortunately with him, and probably his genetic makeup made him at risk for Parkinson's with head trauma. Toxin exposure, so Agent Orange has been linked to Parkinson's, our Vietnam vets who were exposed to that terrible stuff. There's all other fungicides and insecticides, things like that. So, but we don't have a definite one-to-one correlation says if you were exposed to such and such at the age of 30, you're going to get Parkinson's. But they do increase the risk some. So what are the signs? So here's a graphic we'll show you in a bit. So tremor, you might notice that your handwriting's changing, smaller, sloppier handwriting. It's called micrographia, that's the medical term for it. Loss of sense of smell, that one's pretty non-specific. The common cold, things like that can cause changes in smell, so wouldn't hang my hat on that one. Trouble moving or walking. Constipation can precede the diagnosis by decades. but constipation is common, so everybody who has constipation is certainly not going to get Parkinson's. Soft or low voice, so not trouble projecting the voice. We'll get to that with our loud therapy. You see this a lot, so it's called the hypomania, is a medical term for it, where like kind of a mask face appearance. There's just not as much facial expression or blinking, and that's actually part of the disease process as well. Dizziness when standing, maybe passing out, and then kind of stooping and walking. But you have to kind of take that into account that as people get older, they get arthritis in the spine as well. Pretty much everybody gets that, so you have to take that into account as well. But these are the cardinal features that we look for to make a diagnosis. So the tremor, is it a resting tremor that when sitting not paying attention to it, or when you're walking it's tremoring? That's a typical Parkinson's tremor. That's not to say that we used to say the essential tremor, the one where you're using it, holding a cup of coffee, that would not become Parkinson's, because it actually can. It can start to develop some resting tremor. So it could start out that way. Rigidity, stiffness in the arms, legs or trunk. A lot of times patients don't recognize this, and it's something that we pick up on in the examination. Bradykinesia, so the slow movements, family a lot of times might pick up on that. They're really lagging behind when we're out walking, just noticing some of the slower movements than what they're used to. And then the postural instability, maybe they're having falls, more unsteady, getting dizzy when standing up. So these are those other symptoms that can be associated with Parkinson's that aren't movement related. The interesting one is the sleep disorders. So there's something called REM behavior disorder, and that is dream reenactment behaviors that can precede the diagnosis again by a decade or more. And that's where the patient seems to be reenacting dreams, punching, kicking, seems a lot of times it's like a violent kind of dream, maybe shouting out, potentially hitting the bed partner. So there's been reports of people getting injured from this sort of thing, but that could have been a sign that this neurodegenerative process was even starting a decade or more before. Definitely, Parkinson's is more prone to mood changes, depression, anxiety is more common. It needs to be recognized. Cognitive changes can happen, so develop memory issues along the course. That's why it's important to stay very cognitively active plus physically active. You may have seen the commercials for the hallucinations. There's a product out now that's used to treat that. It's something to report if someone's experiencing it. The doctor needs to know about that, plus need to ask about it, because they can happen. There's nothing wrong with having them. It's something that can be treated. This sometimes can be a big problem. Low blood pressure when standing. You might pass out, might fall, that sort of thing. So that needs to be checked. We'll do what we call orthostatic blood pressure checks. So lying, sitting, standing, checking to make sure we're not having too big of a drop in pressure. Another thing that happens is, so a lot of times people start taking high blood pressure medications, but as they get older, and if they get Parkinson's, they might not need those high blood pressure medicines anymore. So we need to constantly be looking to see if we can make an adjustment. So the first thing we'll do if we have someone's getting orthostatic hypertension, dropping blood pressure, is say, well, what high blood pressure medications are we on? Because we might need to move those down. The constipation I mentioned, or feeling of fullness after eating smaller amounts. Fatigue, that's very non-specific. That pretty much happens to all of us. Changes in vision, excessive sweating, excessive dandruff, oily skin, urinary changes, again, the loss of smell, and these impulse control disorders, more likely to take risks, those sorts of things. These are important to look for when you consider a certain class of medications called the dopamine agonists. They can lead to worsening of that. So let's say we have somebody who's a big time gambler, they like to go to the riverboat. A dopamine agonist would not be a good medication for them. It would make them more likely to take risks in the games they're playing. You can get compulsive kind of behaviors, so that's something to ask about when we're talking about medicines that we'll get to soon. So this is kind of what I see. I said I can kind of within 5 minutes, a lot of times we make the diagnosis, but decreased blink rate, some masked face, not as expressive. And a lot of times I'll ask the family, I said, have you noticed that? Or is it different? And sometimes they'll say, no, that's just kind of him or her. That's been like that forever. So you kind of have to take that into account. The stooped posture, decreasing arm swing, walking, the resting tremor, slower movements, that rigidity that we look for, and then imbalance. I don't think I have a slide on the pull test, but that's for the patient. I'll stand behind the patient and their feet are shoulder width apart, and I'll kind of give them a tug, and they need to adjust to that and not fall backwards. If they fall back, I'll catch them, but that's kind of a thing to test and see, are they able to right themselves, because you can lose that with Parkinson's. And this is a typical stoop posture, masked face, and rigidity in the trunk, reduced arm swing, tremor in the hands, sometimes tremor in the leg, that's kind of rare. Oh, the shuffling steps, shorter steps, a little bit flexed in the knees and hips. And then there's various stages, so stage 0, basically you don't have Parkinson's yet, but starts out unilateral, typically on one side will start out, and then it can start to spread to the other side. Disability continues to progress. So these are the things we're really trying to work on to prevent progressing down these stages. So it's not only hard for the patient, but it's hard for the caregivers as well. So caregivers report feeling depressed, feeling helpless. There's financial stressors, relationships get strained. So that's something that also should be recognized as well, that it also takes its toll on the families. Community-wise, there's issues with lost productivity, say at work, that sorts of thing, more healthcare costs. So how do we treat it? So, well, at least from a medication standpoint, if they have mild symptoms, they probably don't necessarily need to be on medicines yet, but that's where we intervene from a physical activity standpoint, cognitive activity, those sorts of things, more counseling at that point. But as we get to medications, they help manage the symptoms, but they don't stop the progression. So if you say, I really don't want to take any medicine yet, but you're not doing yourself any harm. You're not losing out on anything if you don't start taking Cinemet or dopamine therapy earlier. People tend to get fairly decent control of symptoms for 5 to 10 years before they stop work. They don't work as well at that point. You're needing more medication. You can take it more frequently, and then you can get side effects called dyskinesias when you're having to take too much of the dopamine. So if anyone's seen Michael J. Fox, some of the movements that he does, these involuntary movements, those are dyskinesias associated with the medication therapy. And of course, like most diseases, it's not a cookie cutter, so everybody's different with what they need. So this is carbidopa, levodopa, Cinemet. It's a big, long name, but this is dopamine that we need for the brain. This one is basically there to help this get to the brain, so it helps prevent this from being broken down. So the carbidopa part really doesn't do much as far as the disease, except for just help shuttle this into the brain. There's a longer acting form called Rytari on the market. There was one called Stalevo that had this with entacapone. Entacapone helps the Cinemet work for a little bit longer in the synapse. And these class of dopamine agonists I mentioned, these are the newer generation drugs, but tend to have more side effects. That's why I don't use those as much. I do like this one called Nupro. It's a patch, a 24-hour delivery. But getting it approved with insurance is almost impossible at times, so it's frustrating. I don't use these a whole lot. There's Azilect is the one that's been used the most. This is kind of a newer drug. These basically help the Cinemet work better, but I don't find a lot of benefit with those, and there's a lot of expense added. And then we've got this Apoquin or apomorphine. This is an injectable therapy for sometimes patients' medication can stop working abruptly, and they can almost get into like a frozen state where they can't move. So this works really fast. So it's an injection that either the patient or the caregiver can give to really turn it around quickly. So yes, it is an injection. They're working on a sublingual kind of film treatment for that one. It's kind of a rare circumstance to have this. And I'm going back to here. There's I didn't mention it later in the talk, but there's a continuous delivery of dopamine. So the problem with cinema is you just have to take it at least, usually starting out twice a day, then 3 times a day, and sometimes it becomes 4 or 5 times a day. Imagine trying to take the pill 5 times a day and trying to separate it out from food because protein interferes with the absorption. So they have a product called Duopa that is an intestinal tube. So there's like a feeding tube, and there's a cassette that sort of delivers dopamine constantly or all 24 hours or however long you set it. So it's a continuous release. Yes, it's a bit invasive. You have a feeding tube that you have to deal with, but it's a really nice way to deliver the dopamine consistently. And then these are some old drugs that have been used. I don't use these. These have a fair amount of side effects, especially cognitive side effects, but these are ones that you might see maybe friends on it or something. They've been on it for a long time. This one, the amantadine, is used for those dyskinesias. There's a new long-acting form that came out that may be helpful for those medication-associated involuntary movements. So Botox can be helpful. Sometimes patients with Parkinson's get excessive drooling, and it's quite easy to treat that with Botox. Just put some on the salivary glands, and it can help to prevent the drooling. Also, neck dystonia, things like that can happen, and Botox or any of the botulinum products can be helpful. This one came out not too long ago. This is one that helps with that dropping blood pressure when standing. It's a nice product. It's quite expensive. Again, all these new things are so expensive, so it can be hard to get access to it. This is the one that's for hallucinations that came out, and it can be quite effective if those are occurring. In the past, the way you would treat hallucinations is to give drugs that block dopamine. You don't necessarily want to do that with Parkinson's. So this one works through another neurotransmitter completely. This one is for memory, so it's called the Exelon patch, but as patients develop memory issues, it's specifically indicated for Parkinson's-associated dementia or memory issues. The elephant in the room with the marijuana question, the state of Missouri had the legislation passed. It puts us in the medical community in a bit of a bind because we don't have we rely on quality studies to say blinded, placebo-controlled studies. We don't know who's getting what, and then we look and see who did better, who did worse. We don't have that on cannabis. So there's reports that it might be helpful for various neurologic conditions, but some studies are done not blinded. I think the issue with getting studies is it's still federally illegal, so pharmaceutical companies, they're not going to touch it. So that is really an unanswered question at this point in time as far as what to do with the cannabis. So we see some results have been positive. This is per the Parkinson's Foundation. The effects of medical marijuana are not completely understood. More quality studies are needed. Most doctors don't support the available study results because they don't meet minimum research standards. So then the last thing I'll talk about is surgery. Lesional surgeries, that's old. They used to go in and just make a cut in a certain part of the brain, which was irreversible and might help, but it's definitely we have better options today. Deep brain stimulation I'll talk the most about briefly, and then there's at the last Academy meeting there's some kind of ultrasound treatments they're even doing. They're under investigation, but they're using these ultrasound treatments for various things, and KU's doing some of it for epilepsy surgeries and things. So it's kind of a surgery, but it's an ultrasound external treatment. So this is a deep brain stimulator, so implanted in the chest wall, just like a pacemaker, just like a brain pacemaker, basically. So it's kind of tunneled under the skin, and an electrode's placed deep in the brain by the surgeon. This is kind of cool. They have There's two ways to do it. There's an asleep surgery, so like complete anesthesia, it's all imaging targeted, or there's other places that do it with the patient awake. So of course, getting the hole in the skull and all that, they're going to be sedated for that, and they're awake while they're putting the electrodes in, and they're listening. Different parts of the brain have different sounds in these microelectrode recordings they do. So it's a really technologically advanced surgery, but a lot of places have been doing it for so long, they've got it down to an art. They do great with it. So the patient's in a head frame, so the head stays really still. They're using image guidance for exactly where they know to put that electrode. So one or two leads, this is a unilateral. A lot of times with Parkinson's, they'll put them on both sides. So you have two generators. This is a battery pack, lasts for 5-ish years or so. So basically you just have to have that battery pack replaced about every 5 years, and the leads stay right where they're at. We don't know exactly how it works, like sometimes medications that we prescribe, exact mechanism unknown. But I think it's kind of working from an electrical standpoint to kind of smooth out those abnormal movements. So it's completely bypassing the dopamine system. So this is where you want to be, is on time. So you want to be feeling good, you're having better movement, you're not having off time. So off times when the medication is not working, maybe get some freezing, slower movements. But when it's up here, this is dyskinesia, so that's the movements you don't want. So that's where we run into problems with our medications. As time goes on, we start to get off dyskinesias. So that's where we want to be. So, and that's where DBS can help with that. So, I mean, we don't start DBS right away, but you don't want to start it too late either. So there's kind of a sweet spot when the medications just aren't working quite as well. We're starting to get some of this off stuff, some of this dyskinesias. That's when you start talking about meeting with the surgeon to get the DBS placed. This is just symptom improvement in 1 year, 3 or 5 years with the stiffness, the tremors, and the problem with movement showing pretty significant. This is after the DBS was placed. And they're looking at a rating scale at the typical research kind of rating scale. So you can see significant improvements across the board with therapy. So that's, like I said, we do great with dopamine and Cinemet for years, really. I mean, sometimes up to 10 years. We may have to adjust the dose as we go. I try to keep on the lowest dose I can. I'll tell patients they can take some as-needed doses here and there if they want to try that. Don't always have to take the same dose with every time point in the day, so there's some art and adjustment that happens there. But when those medications aren't working and we're getting side effects, that's when we start talking about doing these sorts of procedures. And the Academy of Neurology says about 10 to 20% of people with Parkinson's may be eligible for deep brain stimulation therapy, and probably more to come on whatever this ultrasound treatment is, whether it works out or not. I'm not sure. So you get basically they compare just medicines alone with the Medtronic unit. So 5.1 hours of additional on time. That's amazing over the course of the day. Without the troubling dyskinesias. So you might get, with medicine, you might get more on time, but you get those peak effects, you're going to get those dyskinesias, the movements you don't want. So medications can be unpredictable. The DBS, electrical stimulation, is very predictable. Might be able to lower some medication doses. This is a continuous delivery. This is that pulsatile, sort of up and down. Don't have to worry about GI absorption. So this is that window of opportunity. So sometimes what I'll do is if I feel like someone's getting to that point, I'll discuss it. Yes, it's a surgery, it's certainly invasive. But I tell patients, they've been doing this for some time and they've really got it down. The surgeons are great at this. just to go meet with them, just to have a discussion, learn more about DBS from a surgeon's standpoint. It doesn't mean you have to get up right then, but I think it's good to get introduced to it, and then at some point work in, me, the surgeon, patient, have a discussion, say, we think it's time, let's get this thing done. So if you don't respond to the dopamine, not responding to the medications at all, that's not a candidate. It's the DBS isn't going to help. Even if the patient's already severely disabled, so if we waited too long, now the best we can do, we're in a wheelchair. DBS is not going to be indicated in that situation. Of course, if they can't have the surgical procedure, and then if the patient has dementia as well, so if they develop dementia fairly early in the process of neurodegenerative disease, then it's been shown that the DBS doesn't seem to help those patients. So, who does DBS? So, North Kansas City, we're working on it. So, Dr. Kinsman from KU comes over, so we've discussed DBS, and is that something that we can do in North Kansas City? And it's certainly being looked into being offered as an option. KU's been doing it for many years. When I was a med student, they were doing DBS. St. Luke's on the Plaza does it, and Research Medical Center. As far as I know, are the only sites in town that are doing DBS. And I just threw up there's lots of other websites, but whenever you're doing your web searches on things, just make sure it's a good, trusted site. There's a lot of misinformation out there. You can't go wrong with Parkinson Foundation. Michael J. Fox, if you really want to see what's up on the research, what are they looking at, that's a good site. I'm partial to Mayo, so Mayo Clinic. Medtronic has it's a great site. I think you can even watch the DBS surgery. They've got videos. I think they did a 60 Minutes special on it, where they tracked the patient at Case Western maybe, where you saw the whole process. And what else can we do? Well, we've got our different therapy modalities, and Rocksteady. I was sitting at home, CBS Sunday Morning came on, and it was a story. I don't watch it that often, but it was on Parkinson's and boxing therapy, and it was in New York City. And it looked great, and I was looking around, and I think maybe there was, way down south, KU might have been doing something with it at the time, I'm not sure, but I said, why can't we have that? And it's New York City, big city, why can't we need that in Kansas City? So that's when I approached the administration, and Jill got involved, and they just took it and ran. Administration was very supportive, sent them out to Indianapolis to get the training, and this has just exploded from there. It's been fantastic. Patients love it, and the ones that participate, I'm sure, would say that as well. So I'll turn it over to you guys.
Thank you.
Hi guys. All right, so Rocksteady Boxing. What is that? So that is actually a high intensity workout, and we focus on big movements, we focus on balance and posture, we focus on functional fitness, so things that you want to do at home, but it's been hard. So what we do helps improve your ability to do that. But we also focus on being a community. We focus on supporting each other, checking up on each other, and being a community. So Rocksteady Boxing started with Scott Newman. I just realized that, guys. There we are. All right, so Rocksteady Boxing started with a gentleman by the name of Scott Newman. He is the former Marion County prosecutor. He was actually diagnosed at the age of 39. So Scott was sent home, not a lot of hope, and it dawned on him, I've got to get moving. So he started training with a woman by the name of Christy Fulmar, who happens to be a champion, a world champion professional boxer. They started doing one-on-one training, and he noticed, hey, I'm doing better. I can move better. I feel better. So he went out and got a couple of friends, and they started all training together. And so Rocksteady Boxing started. So it's actually grown to be worldwide now. I mean, if you go on their website and look at everywhere that they are, it's crazy. So that's kind of a little bit of background about it. You ready?
So why boxing? So basically, why boxing, guys? And again, we would not have this program if it wasn't for Dr. Kosa. So thank you very much for this. This has been an amazing program. We started out about a year and a half ago with 4 people, and we are up to 58 participants now. So it's pretty good. We have 9 classes, so it's pretty awesome. So basically, our Parkinson's people come to us, and they come to us and they want a condition for agility, speed, endurance, accuracy, balance, hand and eye coordination, footwork, and overall strength. And at Rocksteady, what they want to do is they're fighting against their opponent, and their opponent is Parkinson's disease. And that is why they come to us. So true boxers, they are literally conditioning for these same elements. They're wanting to improve all of these things as well. So basically, medical researchers have found out that basically boxing is the most intense type of exercise that there is out there. So we've sized them up, we've measured them up, top to bottom, we've done our tail of the tape, and we've come to a surprising conclusion, pound for pound, that boxing is the way to go for Parkinson's patients.
Okay, so our classes, because that's the big question, right? What happens in our classes? We set up stations, and our stations, again, focus on balance. They focus on eye-hand coordination. They, a crowd favorite is posture. We also do some strength training, because that's where it's functional. So you go through the circuits, and then we get done, we do a cool down, we do a warm up in the beginning, and then we all put our hands in a circle, and we yell, because yelling is fun. So that's kind of a breakdown of class. I want to enforce a high intensity is different for absolutely everyone. We do not expect everybody to have the same intensity level. That would be crazy. We just ask that you start where you are, and we will help you get to where you want to be, okay? So you just start, that's the biggest step, and from there, we just have some fun, all right? So we do have different classes. We would need to do an assessment, and we do have a sheet out there that you can see Jamie and Michelle, they're coaches too, and they can kind of set up an assessment with you. You'll come in and you'll kind of see what we have, and we'll do an assessment and you'll join a class. It's pretty much that easy. If you also want to come out and see a class, give us a call. Our number's out there, and we'll kind of go over what class might be best for you to come and see. That way you'll see exactly what it is that you will be doing, okay? So we do have our classes up there. Please note that Saturday is an all levels class. It's kind of nice to get together with, other groups and get to know them a little bit better. So there's our number. If you have a pen and paper, take a picture.
And also, guys, just want to tell you that effective, actually officially in January, we're starting a Parkinson's support group. So if you're interested in that, you want to sign up, you have any questions, we will be out at the table after the presentation. So.
Absolutely. Oh, brunch and punch. Do you want to talk about brunch and punch? Okay, so we're going to have some fun. We do every Tuesday and Thursday, but we're going to have more fun. So we have a brunch and punch coming up. So that brunch and punch, you're going to be able to come and talk to family doctors. You're going to be able to, check out the Rocksteady Boxing. We'll have people there kind of doing a demo. Cycling, we're going to add cycling to our list of what we're going to offer. So on the off days when we're not boxing, you can come and spin. Tai Chi is amazing for balance. You'll also get some food. So it's a good deal. So Dr. Kosa will also be there talking as well, so you can come see us then too, okay? We have these flyers out on the table, so you can pick one up and take it home as a reminder. All right? So now we have our lovely PTOT department to talk to you about the Big and Loud program.
Good afternoon. My name is Sarah. This is Brent. We are from North Kansas City Hospital in the Outpatient Rehab Therapy Department. I'm here to talk about the Big and Loud programs today. So just a little definition of what Big and Loud programs are. Those are 2 separate programs that we offer in the outpatient department. LSVT, BIG, focuses on reestablishing intensive sensory motor system movements to help restore normal movements, size and speed, so restoring normal arm movements, leg movements to help with balance and walking. The LSVT Loud program is a program that helps to treat the Parkinson's related voice and speech problems that I'll get into a little bit later here. We now have 3 certified occupational therapists that provide the big program and 2 certified speech pathologists that can now provide the therapy there. So problems that you may encounter related to Parkinson's combined with both of these areas. Problems in self-perception, so not being aware of how soft your voice is, not being aware of your small body movements, leg movements, arm movements, unaware of your poor posture, problems with balance, increase in falls. In regards to communication, you may notice that your voice is progressively becoming more hoarse. Your voice may start to tremor. You may have slurred speech or more imprecise articulation. Your family members may be telling you that they can't hear you. You're having to repeat yourself often, which can be very frustrating. Decreased facial expression, and of course social isolation or pulling away from some of those more social situations because of some of these difficulties. So to talk about each one of them individually, the LOUD program specifically focuses on improving awareness of volume. That's our primary target with that program, and as we're finding through research, it's improving so many more things associated with speech and communication. What we're finding is it expands or can expand the vocal range to increase your vocal expression. We work on enhancing your ability to self-cue and become more aware of how soft your volume is so that you can use more effort to get to that normal volume range. And the exercises that we'll talk about here in a second do help to strengthen the respiratory tract and the vocal cord muscles themselves to help improve your voice. Yep.
Okay, so very similar to the LSVT Loud program, which the big program is kind of modeled after and came after. Step number 1 with the LSVT big program is to improve awareness of diminished or atypical movements. So I think everyone who has Parkinson's disease may understand that, hey, I know I'm moving a little bit differently. I know I might be slower than I used to be, or it may take longer to get a jacket on or a long sleeve shirt on. But in the act of actually moving, I think it may be, we know it's harder for individuals to recognize when they are moving differently. So you may start out with a big posture and then slowly over time start to stoop, or your steps may get progressively slower and smaller as time goes on. So the first real step is recognizing the need for a change and to recognize when that need is. The second focus is to improve the awareness of how much effort is required to move normally. That's what that big stands for. It stands for effort, and it stands for intensity, and it stands for what we're thinking of when we are moving. So we want you to be comfortable with producing those bigger movements to scale your movements back up to normal. We're not looking for anything weird or silly when we're walking. We're not looking for our arms swinging up high to the ceiling. We're looking, when we say big, we mean bigger movements, higher intensity to scale that movement back up to normal. Increasing motor output, so increasing overall muscle activation to produce these normal movements, and I think an important aspect of that is getting you comfortable with these larger movements. I've had a number of patients who they start to walk and they'll be doing awesome, and I'll say, how does that feel to move that way when you move big and you're walking? And they say it feels kind of weird. It feels like I'm bouncing up and down, or it feels like I'm walking a little silly. And I'll say, well, here's a video of yourself, doing it big, and then here's your pre-treatment video, and they'll say, wow, that looks normal. So again, moving big, they'll say, wow, that looks a lot more normal than I thought. felt different. So again, it's about that sensory motor mismatch of the difference between how it feels to move and how you are actually moving. The final aspect of treatment is, of course, developing those self-cueing skills so that you're not requiring an external cue from me to move that way. We want you moving big outside of the clinic. It's not about moving big while you're just seeing me. It's about going home and making those big movement changes. So we want to make sure people are able to cue themselves accurately. And over time, during the course of our therapy, we start to scale back those external cues which I provide. Both the loud and the big programs are fairly intense, and I believe that intensity is what separates them and what makes them more successful than many of the 1 to 2 to 3 time a week standard therapy protocols that you would see sometimes. And so they're 4 times a week, they're 60-minute sessions, and you are one-on-one with the therapist for the entire duration of those treatments. So it is a protocol, and everyone gets, we say standardized but also individualized. And what that means is everybody is getting the same amount of research volume, or the same amount of therapy, but it's based on an individual. So where we might start with an individual working on these exercises in a chair, another one might be stepping over hurdles or on a non-compliant surface to challenge their balance a little bit more. So we can adapt it for whatever stage individuals are in. In addition, each participant identifies key areas that they want to work on in both the loud and the big programs. So, working on speaking loud in a conversation, or working, someone might say, I want to focus on getting in and out of the car. That's a hard area for me. So for that person, we'll work on getting in and out of the car, and for another, we may work on something different. And then to reinforce the fact that we want people moving better at home, and to reinforce all of the cues we've been giving throughout the course of therapy, there is daily homework with each therapy. Okay, so we start out each big session with 7 daily maximal exercises. They are large compound movements. They are very intense, and I think it starts as a good way of getting you comfortable with the amount of effort we want to get when we transition to more functional movements. So each one is going to challenge you differently. They all have functional components to them. So they'll be sidestepping and reaching, or they'll be backstepping. And these are things that you do on a day-to-day basis, whether or not you're opening up a fridge or reaching out into a cabinet. So they are very functional and have good application to day-to-day life. So we start with those, and then we focus on our 5 functional component tasks, which are these functional things that you identify and say, this is what I want to work on. So a very common one we have is putting on a long sleeve shirt. We have a lot of people that get stuck back here, or we have a lot of people that have difficulty getting up in and out of a chair, rolling out of bed. So each person identifies these individual needs, and we work on those using our big movement, big effort, high intensity. And we train those, and again, that serves as another form of reinforcement when you're at home. You'll say, I've done this before in therapy, and it'll be another source of cueing. And then in each big session, we work on walking, and that includes posture, maintaining big steps, and maintaining that good arm swing. But again, our only focus is moving big. I don't want you to get boggled down by, I need to do heel-to-toe steps, or I need to worry about my left arm. Our only focus is moving big, because that has an easier impact for people to carry over to home. And then finally, we work on a hierarchy task, which is a kind of multi-step, multi-level complex task that people identify. So it's a bigger task, like playing golf. So we can break it down using those big movements and get you back out onto the golf course. Or riding, like Dr. Kosa said, people say, I want to ride, that's what I enjoy. And so we work on riding with big legibility, and there are some other strategies that we use during that.
All right, and back to, so LSVT loud, kind of going over some of the treatment layout for that as well. So again, going back to that, the primary focus of LSVT loud is thinking loud and feeling loud during everyday conversation. Because again, patients usually are not aware that they're talking in a volume range that's too soft. What feels normal to them is actually too soft, so they have to get comfortable with feeling louder and thinking louder and knowing that they're in a normal volume range. So we start off each exercise or each therapy session with exercises to work on strengthening the vocal cords. Because like I mentioned earlier, with the progression of Parkinson's, the voice box, the vocal tract, and the vocal cords do weaken. So we strengthen the vocal cords with a focus on using more effort and increased volume with each exercise. So we'll teach you to do exercises where you're holding out vowel sounds as long and as loud as you can, singing up and down the musical scale using more effort. And then shifting to a more functional focus, we do work on using that loud voice to work on functional phrases, functional sentences, so phrases that you use every day in your home environment or your work environment. And we work with you to pull those specifics out and make it very functional for you so that it's something you're using on a daily basis. We shift to doing periods of loud reading. And in fact, during the last half of that hour session, we're doing nothing but loud talking, loud reading, and loud conversational practice. We'll start in the therapy room with software where you can see your volume and you can see the therapy room. And we get you comfortable with talking loud and thinking loud in noisier environments with people walking around you in the therapy gym, down in the cafe. Okay, and then again, loud practice assignments is part of the homework program as well. So we give you assignments where you are practicing your loud voice at church, out at the grocery store, meetings, and then I have you bring that back and we talk about how things went. And the goal with those carryover exercises is to try and use that effort in various settings and keep that same effort level that you use in therapy. So again, with both programs, we each have a single target. The LSVT Loud, we're working on the loudness. He's working on big movements. It's a very high intensity program. Again, 4 days a week, 1 hour sessions, and each program is an hour each. So if you came in and did both at one time, you'd have an hour with the loud, an hour with the big. Over the course of those 4 weeks, we are increasing the complexity of the therapy tasks, moving towards that independent ability to self-cue and regulate your volume and your movement. Teaching techniques again, we're modeling, we're shaping, we're driving effort, we're working to stabilize, doing a lot of visual feedback so you can see and feel how those movements actually look and sound. And again, the calibration part, or where we're trying to train you to feel and think louder and bigger, starts day 1 of treatment. So again, we're working with you to recognize the need for louder volume and recognize that need for bigger movements, because that is something that with Parkinson's you aren't aware of, and that self-perception is impaired. So steps with that, again, is increasing your comfort with using louder volume while speaking. We're working on having you practice with different communication partners, variety of settings. With the big program, increasing the patient's comfort with bigger movements during daily tasks. So like he mentioned, getting up from a seat, getting in and out of bed, and whatever tasks are not going well in your daily activities, we're going to try and apply that to make it very functional. Both programs are highly evidence-based. There is more than 20 years of research funded by the National Institutes of Health. Documented improvements include improved improved vocal loudness. The nice thing about the loud program, there's a lot of indirect things that have been improved through the research, like speech intelligibility, facial expression. There's some studies now that show it improves swallowing ability. The big program is showing improved balance, ability to complete small motor tasks such as writing and buttoning clothes, faster walking, bigger steps and arm swings. Okay, in order to be a candidate, again, we can do this at any stage of Parkinson's. I do believe it is beneficial to get in as soon as possible. I think the earlier stages do benefit more. Must be verbal, must have cognitive abilities to follow directions. Again, if you have cognitive difficulty, you can still do the program. Usually family support is very helpful. Be able to commit to intensive treatment and the homework schedule, which is very important. And there are other neurological conditions that this program can be helpful for as well. Okay, candidates, strong family support, very helpful. For the LOUD program, we do require an ENT consultation before we can initiate the 4 weeks of exercises. We can still see you first in the clinic and make sure you're the candidate and then refer you to the ENT. That's just to make sure that your vocal cords are healthy, that they're not irritated and swollen, or that any other conditions are present where the program would aggravate any pre-existing condition. It's adaptable for individuals with a history of injury. Big movement training is done within a safe, tolerable range of motion, so that can be modified for other conditions. Okay. I think that's all we have.
Dr. Kosa has 10 or 15 minutes to field some questions. I would ask that you direct your questions to him so we can get him back to the hospital to his patients. Shanna and Jill and Sarah and Brent will be out in this hallway right after the question session, and they're happy to talk with you and answer questions.
My name is Kathy. My grandmother had Parkinson's back in the 80s. So I'm surprised that there haven't been more advances in the research since then. Can you be more specific about the main centers besides Mayo Clinic that has done the research in Parkinson's? And why you choose to prefer Mayo over what other sources that you can tell us about for their research?
Well, so research is being done all across the country, so I'm just really familiar with Mayo, so that's why I mentioned them. But I know that, like on the Michael J. Fox Foundation, they've got a lot of links to what different research is going on, but there's multiple academic centers and even non-academic places looking at experimental treatments and drugs. So believe me, that's ongoing in the academic world. And as far as, I just threw up some helpful websites, but you could just as easily, go to Harvard or other, websites like that. Medscape is a really great resource. So I just wanted to put that up, just direct people to. I just wanted to say, look at good quality sources. Because of all the misinformation that's out there, not just with Parkinson's, but lots of different disease processes. There's various unproven supplements that are being sold that people are making money on that aren't necessarily shown to be helpful.
Hello, my name is Lorenzo Hammond, and my mother has Parkinson's. And one of my biggest concerns is driving, and don't want to offend anyone, but at what point do I step in and say, hey, Mom, you know, because she's very independent and she has the motor issues. So she says it doesn't impact her driving, but at what point do I really take issue with that?
Yeah, I think that's our physical and occupational therapy departments can really be helpful. If you go along with and pose that specific question about, do you think that driving would be safe? And there's even places that are doing driving simulators. Do we have anything like that? Or
No, we have a Dynavision board which we use, and there's some established safe level, borderline level, and then definitely unsafe levels. And that's part of a comprehensive thing we do, but we don't have any simulators. And then there's some places I think that actually go on the road.
Oh, can you repeat that? Yeah, just.
come on up here. Yeah. I'm deferring to my therapy experts. There's a place where you can do like a formal driving evaluation that the therapist, I think, rides in the car and the therapist assessment, but it can be quite costly too. That's been the issue with that.
Yeah, we do have sort of a comprehensive evaluation with Dynavision light board, and obviously a range of motion and strength test, in addition to gross motor coordination testing to kind of get an idea of where the line is safe, unsafe, or borderline. Unfortunately, there is a borderline category where there's no certainty. Obviously, we'd always err on the side of caution if that were the case.
I think it's also very valuable for you to ride along and monitor that. Yeah. But I find that with dementia patients as well, that I really say that if they're concerned about the driving, they need to be riding along and seeing if they pick up on anything.
My name is Jerry. I noticed the meds that you put up. I just wanted to see if you're familiar with a man by the name of, I know I'm not going to pronounce this right, Don Pizel, D-O-N-E-P-E-Z-I-L.
Yes. Yeah, so it's in the same class as that ribostigmine patch. The only reason I didn't put it up there is it's not specifically indicated for Parkinson's and memory. Do we use it? Yes. The patch can be quite expensive even though it's generic, so they have very similar activities, so it is used for memory with Parkinson's as well, yes. That was the old trade name was Aricept for that one.
Is a movement specialist just another term for a Parkinson's specialist? And in the Meritas Neurology group, are you the only Parkinson's specialist?
Yeah, good question. So it kind of depends on the movement disorder specialist. There are some that they mainly just do Parkinson's, but there's lots of other movement disorders, but they don't necessarily treat those. So a movement disorders specialist has done a neurology residency and then goes on to do a fellowship in movement disorders typically. A lot of those are at academic centers. KU has 3 or 4, I think, and St. Luke's has, I think, 2. So I'm actually a general neurologist, so it means I treat everything. When do I use our movement disorders colleagues? Well, I'll do that if we think someone's heading towards DBS. I might ask that question to them. Or if someone's really complicated and I don't know if this is Parkinson's, I don't know what this is, and then I'll ask for help. So then you get into a situation where you kind of have your regular community neurologist meeting with our super specialists that you might go see once or twice or periodically, and then they'll make recommendations, and I tend to follow through with those. So that's how we use they call them subspecialists. So you've got movement disorders, you've got neuromuscular, headache, stroke, those sorts of things. So a lot of medicines heading towards being super specialized. Everyone in our group are general neurologists, so we treat everything. We all may have our certain areas of particular expertise, but being an official movement disorders expert is typically you've done a fellowship and you've taken a board certification for that. same as the medical marijuana, we just, CBD, all these places are popping up on every street corner, and from what I understand, it can be quite expensive too. Like I've heard about $100 a month, and it's quoted to treat everything basically. And we have no literature really to point us in any direction. So I've seen patients using it for various things. Some think it helps, some don't. So it's just hard for us in the medical community without any real research to say yay or nay on those things.
You say yay, but we don't say nay. I mean, if one of your patients asks you about that, would you just say do not, or pick someone?
I say I don't know, but I think the CBD doesn't have any of the THC component in it, so I actually don't have a problem with it, but I do tell the patient, I say, well, I've heard this stuff can be quite expensive too,
Yeah.
so I'm not against it. And it's not to say that when the medical marijuana thing finally comes out, I'm not necessarily totally against that either. I just want some more studies, and hopefully those are forthcoming.
And can we get a copy of your slides, email or otherwise?
It's fine with me, sure, yeah,
Okay, thank you.
absolutely.
One more question? Dottie?
We can do a couple.
Yeah.
You mentioned Primadone and Pramipexole, but you don't use those. Could you talk about that?
Primadone I use for the essential type tremors, so that one, either that or beta blockers. I don't use Primadone for Parkinson's, unless they really have that whole, postural tremor holding it out, it might help that. It's not to say I don't use Pramipexole, but I just feel that those have more side effects. I'm more of a levodopa practitioner. I still think the old drug's still the best. But some patients don't respond as well as you would like, and they may respond to the dopamine agonist, so I'll use them. I do like, they have long-acting forms of the dopamine agonist pills too, which is nice, so you can get a more steady release and activity. But I always do screen for any underlying compulsive behaviors, so actually if someone's prone to gambling or lots of shopping, that sort of thing, it actually can make it worse. So I really watch for that and ask questions about it. There was actually a class action lawsuit, I believe, against Meritas for that reason, for these compulsive behaviors that developed.
I really don't have a question. I just want to tell you something about Dr. Kosa. It's good. His family moved from Virginia to Liberty. And I was fortunate enough to work with him in 3rd grade in Liberty. And
He was my teacher.
and what a pleasure it was to meet him in a medical way. I don't have Parkinson's, I don't think. But anyway, I'm so proud of you. And me too. One other thing is I happen to be, I went to Mayo's for something for myself, and I went to the neurology department, and I told Dr. Excomit that I had been to see him, and he said, "Oh, he's a good doctor."
Thank you all. I hope you found our morning and afternoon informational, and please stop by our tables out in the hallway.